We do have some time for questions, recognizing that we've probably gone beyond everybody's lunch break. Are there any questions for either Ian? We may not have Sai still on, or Naomi. Is there anybody else in the room or online who has a question? Ian, would you go ahead, please?
Yeah, Naomi, I was just considering, obviously any intervention in relation to post-sepsis syndrome, you'd like to target patients, I guess, who are most at risk of developing the syndrome. So I was just wondering, is there any research being done on, say, machine learning, a machine learning algorithm that might predict who's at high risk of post-sepsis syndrome prior to discharge, and that they would be the ones that you'd follow up perhaps more closely?
Yeah, great question. So while I don't know of any papers that have done machine learning prediction, we do know that there are at-risk populations. And so I guess that's, and you would know this as well, they're built into your kind of your sepsis pathway, where you're looking at like the elderly, the young, people who are immunocompromised, etc. So I guess there definitely could be more work done around that to actually identify those individuals who are so I should say they're the ones that are most likely to get sepsis, but then also it does flow on to commonly having post-sepsis syndrome as well. So there could be further work in that space, definitely.
Thanks, Ian. Rob, is there a question in the room?
I just wondered if all three speakers could give a definitive endpoint they would be hoping to reach in about 10 years' time, just for our insight.
I'll ask Naomi, you go first.
Yeah, absolutely. Definitive endpoint would be that we have an embedded post-sepsis model of care within all of our health services across Australia. It's obviously going to take, we can recommend what the model might look like, but actually without it being implemented, then we're not going to make an impact. So that's what I want to see.
Thanks, Naomi. Yeah, an interesting thought on there is the clinical care standard isn't exactly, it's not mandatory, is it? It's not, it doesn't form part of accreditation. So
not at the moment, but that's being worked through to try and have that as a mandated approach.
Yeah, fantastic. Ian, what about your thoughts? Where do you want to be in 10 years?
Well, in 10 years, hopefully retired. But anyway, I think, but I think I'd like to see our sepsis prediction algorithm embedded into the EMR of every Queensland digital hospital, and that the Sentinel dashboard model of care might be extended to other conditions apart from sepsis.
Thanks, Ian. Fantastic. We do have one question, Naomi, from an online participant. How effective or impactful is it to have a sepsis CNC in impacting bedside care, improving documentation, and post-sepsis follow-up?
Yeah, so while we haven't had any papers on this, we do know in Australia, we do know from international work that through the STAR program, I don't know if anyone has heard of that, where they've had what we would consider as a sepsis CNC actually follow patients and then undertake post-sepsis follow-up through phone calls, and then targeted education and feedback back in to the hospital system, as well as referring patients on. So I think that is definitely going to be an impactful tool that, again, I think would help across that spectrum of care. If we think of early awareness, recognition, and follow-up, a sepsis CMC would be great. And that's something that's been recommended through the clinical care standard as well. I think there's a pediatric model, sorry, Adam, in WA, but not in adults yet.
Thanks so much, Naomi. Jason in the room?
Great presentations. Thanks, both Naomi and Ian and Sai, to your left. This question's for Ian. Ian, I'm interested about the model that's been developed and whether or not it is a model which will be iteratively improved with time as maybe the treatment of patients evolves, the kind of things that are being done before they reach the hospital, maybe more monitoring parameters start to develop. Could you see that the models that you have, or as sophisticated as they are, they may need to adapt over time, maybe every 3 to 5 years or so, to make sure that they still remain optimal?
Yeah, no, good question. And the answer is definitely yes. We know that these models can be at risk of, model drift due to data drift, concept drift, etc. So we will be monitoring the statistical performance of the model as time goes by. So I think, so that's an important outcome. And I think too that we know that large language models, ours is a machine learning algorithm. It doesn't include large language model as such, but there are hybrid sepsis prediction algorithms that are even better in terms of their accuracy because they can actually screen EMR notes, free text, and that provides more information. Number two. And number three is that we're working with the Queensland Ambulance Service to see whether we can input pre-hospital data into the algorithm as well. So we actually can recognize sepsis earlier so that even by the time they arrive in ED, we may say, this patient is definitely developing sepsis and therefore needs treatment immediately. So yeah, in answer to your question, there will definitely be further developments and refinements as we go through time.
And Ian, maybe I could say as well, what's interesting about regulatory approval of AI at the moment is that when you get your AI approval, your let's say FDA approval of your model, that model then becomes fixed. So you have a regulatory approval that says, sure, go ahead, here's a model that's been approved, but then it can no longer evolve. So your predictors are fixed, your effect sizes are fixed. And so that presumably that limits the value of that regulatory approval.
Well, yes, that's true, Adam. But I think the FDA is sort of looking at what they call pre-planned change program or change protocols. In other words, they realize that these tools will continue to evolve, so it can't be fixed in time, and there will need to then be a process whereby, okay, we can anticipate that certain refinements will need to be done, perhaps at certain time intervals, and we're notifying well, at least the FDA is saying, as long as you notify us and make sure that you've given us further evidence that the model continues to perform well, okay, that's fine. We may not need you to go back to scratch and have a full formal review. But I think in terms of the TGA, well, that's still being worked out. And I think that this is still very much a regulatory nightmare. People aren't too sure, particularly with large language models and generative AI, just how we're going to regulate what is a fast evolving technology. I can express my own personal opinion, but I won't go into that now. But I think that these regulatory standards are still in the process of evolution.
Thanks, Ian. That's at least somewhat encouraging to hear. I'd just then like to thank again everybody for attending and joining the meeting today. Thanks to Associate Professor Naomi Hammond, to Professor Ian Scott, to Dr. Sai Rahman for your talks. Sorry for chairing it so abysmally and letting everything run over. And a final thank you to our sponsors, the CRE Sponsor Seminar Series sponsors, Pfizer and University Hospital Neem. And please go ahead and complete the feedback survey and Naomi's survey. Thanks again for attending.